So in the history station, there will be the candidate, examiner, role player, and the invigilator. So in there is 5 minutes, then 14 minutes, then 9 minutes. In the first 5 minutes, what you will do? Candidate enters the station. He reads the candidate information sheet. And at 4 minutes, invigilator confirms candidate has read the information sheet. So 4 minutes will be there from the time you enter to read the information sheet. Invigilator announces the station has started. Then 1 minute, in 1 minute, what? Examiner enters the station and examiner introduces self and checks the candidate number. Examiner provides the introductory statement. So first 4 minutes, you will read the information provided to you. And in 1 minute, the examiner will introduce himself. And I don't know what introductory statement he will provide. Any idea? Anyone has the idea?
No, just he provides like this is like I'm today to take your history station for this. So did you go through it like this in the mock? He just asked like this. Are you ready for it? Like, yeah.
Maybe they will
Because
just
already you would have read the information, right, from the sheet they have provided.
Yeah. Yeah,
They will
but he will
introduce you
confirm.
to the role player. That's what was in Mrcpch. I mean, the extended clinical, they have mentioned that this is your role player, and they will mention the name. That's what they have mentioned, I think.
Okay, maybe he will introduce himself as well as the role player to you. Okay. So all these things will go for 5 minutes. Then the total time for history taking for you is 14 minutes. Examiner asks the candidate to take focused history. Candidate takes focused history from the role player. So at 9 minutes, invigilator announces that you have 5 minutes left. So we will divide it into 9 minutes and 5 minutes session to gather your history. At 14 minutes, invigilator asks candidates to stop taking the history. Then candidates, in the 9 minutes, what happens? Candidate discusses the patient's problems and management plan with the examiner. Invigilator warns at 3 minutes. So when the discussion is going for 9 minutes, at 3 minutes, there will be a warning. At 23 minutes, invigilator announces that the station is over and asks everyone to remain in the station until told to move on. So when I give you the scenario, I will give you 5 minutes. Then after 5 minutes, the scenario will go on for 14 minutes. And then 9 minutes will be the discussion. Okay.
Dr. Noor, this an extra minute they're giving in this online exam, because when we are shifting from one window to another, right? That is when this 1 minute will be utilized. Actually, you'll be given only 4 minutes for preparing your case.
So Dr. Vindhya, you can take the case now. I will tell you. Hello.
Hello.
You can hear me. I will tell you the case now.
Yes, yes, Dr. Noor.
Okay, so you have Harmi. Okay.
Harmi.
Harmi, Hermi, is a 4 years old girl. Okay, presenting with chronic cough and mild grade fever.
Okay.
Her weight is on 3rd centile. Her height on 9th centile. Okay. She also reports several episodes of chronic diarrhea with abdominal distension.
Okay.
Since her 2nd birthday.
Okay.
Okay.
Yes.
Take history from her mother, Mrs. Cheryl. Okay.
This is Cheryl. Okay.
Cheryl and Hermie. Okay.
Okay. I'll just repeat, Dr. Noor, correct me if I'm wrong, okay?
Okay.
It's Hermie, 4-year-old girl, present with chronic cough, with mild fever, weight on 3rd centile, height on 9th centile, chronic diarrhea plus abdominal distension since 2nd birthday. And Mrs. Cheryl is her mother name, right?
Yeah, yeah.
Okay, so you'll give me 4 minutes, right?
Yeah.
Okay, thank you. Yeah. To Mrs. Cheryl, mother of Hermie.
Yes, doctor, this is me.
Okay, my name is Dr. Bindya and I'm one of the children doctor. Actually, today I'm here to discuss about the Hermie's condition, as I got a referral from your GP that Hermie she's 4-year-old girl and she had problem of chronic cough and mild fever and she's not growing well and you have concerns regarding her diarrhea and tummy pains and tummy is getting bigger. Am I right?
Yes, doctor.
Okay. Mrs. Cheryl, can you tell me more about her cough?
Actually, I am seeing her coughing from a quite long time, maybe from 3 months, but
Okay.
it was not too much. She was coughing sometimes. I thought it's just due to the change of weather, and but from 12 days it's increased. She's coughing too many times in the day, and sometimes she coughs so much that she vomits with the cough.
Okay. From how many days you told me that it's been increasing?
12 days.
Sorry?
12, 12. 1,
12.
2, 12.
Okay, I'm sorry. 12 days. Okay, okay. Can you tell me that what is the type of cough? I mean, is it more with the phlegm or without phlegm?
There is flame for her, and it is whitish in color. And it comes when she continuously coughs, and there will be vomit, and in the vomit we can see this sputum.
Oh, okay, okay. And that's also white in color.
Yeah.
Is there any blood or anything like that?
No, I did not see any time blood, but I feel that the cough is increased and her quantity of sputum is increased.
Okay, okay, okay. Can you tell me that with this cough, how much it has affected her sleep and activity?
Actually, her cough is most in the daytime. It's not a nighttime cough.
Okay.
Before 12 days, she was sleeping very well, but now I can say that sometimes I check her temperature in the sleep. It will be 38, 38.3 like this. I just give her paracetamol and make her lie down. Her cough is not much in the night.
Okay, okay, okay. Can you tell me, is there anything which is making this cough better?
Yes, I use nebulizer for her, because previously also she used to use this. Doctors had prescribed me. So I give her some nebulizations, and I am not seeing much improvement in these 12 days with these medications.
Oh, you are putting something in nebulizer? I mean, what's the medicine
Yeah,
which
I
you're
am
using?
giving her Ventolin only.
Okay, okay. Only Ventolin. Do you remember the dose?
Yes, it's the doctor had told me to give 0.5.
Oh, okay, okay, okay. Okay. Is there anything which is making this cough worse?
If she plays a lot, sometimes I feel that it's becoming worse.
Okay, okay. Can you tell me more about her temperature? As you says that it's your temperature, you're recording it's 38 and it's getting better with paracetamol, right? And it's been how many days for
Yeah.
this temperature?
Now it's 5 days, more than
Oh,
5 days, no? But anytime It's just, it's less than 38.5. Never it crossed 38.5. No.
And it's present every day?
Yes, yes,
Oh,
from 5
every day.
days.
Oh, okay. And what about the cough? Cough is also present every day, or there are some days which are cough?
Before as I told you, from 3 months she has cough, but it was not every day. But from now 12 days, every day she has cough.
Okay. And as I told by GP that she is on 3rd centile. So since how long you notice that her weight is, I mean, she is not gaining weight or she's losing weight?
This is from her 2nd birthday.
Okay.
After till she was 18 months, she was okay, I feel. Then afterwards, there was a drop in the weight.
Okay. And since then, as I have been told by your GP that he has some diarrheal illnesses as well, right? There was some complaint of diarrhea.
Yeah, she has loose watery diarrhea. When it comes, it will last for around weeks, means 2 weeks, like this it will last. And also there will be difficulty in flushing.
Okay. And along with this diarrhea, as you told, it's large amount and it's difficult to flush. Along with that, is there any vomiting or any, what's the color? I mean, is there any blood in the stool, anything like that?
No blood in the stool. Vomiting sometimes, not regular. Sometimes vomits. Only the food, no blood in vomiting, no blood in the stool. But there is sometimes the tummy is distended.
Okay, sometime it's not like
I see some tummy distension.
Okay. Okay.
No. When she has these attacks of the diarrhea, there will be some tummy distension for her.
Okay. Do you feel any change in her coloration? I mean, do you feel she looks more pale or she look yellow, discoloration, anything like that of her eyes or of her skin?
No yellow, but she's pale.
She's pale. Okay. Do she
She's
complain?
pale.
Yeah. Do she complains of any headache or her nose being blocked all the time and anything like that?
No headache and no nasal block.
Okay. Any concern? Do you have any concern regarding her hearing or vision?
No problem in her vision and hearing. It's fine.
Okay. Do she anytime complain that her heart, I mean, she feels like a racing heart or any such problems, or is she getting short of breath?
She's not telling me anything, but whenever she has this fever, I feel that her heart is fast only.
Okay. Do she get short of breath?
Yes, sometimes. When I see that there is some shortness of breath, I give her the Ventolin nebulizer.
Okay, and with that she get better?
Yes, but now from 12 days, no response.
Okay, no problem. Is there any, do you have any concern regarding his PE? She's fine with that?
No, PE is fine.
Okay. Do you feel that she had again and again she getting infections of skin or any urinary infections or anything like that apart from this chest problem?
9 minutes over.
Okay, 9 minutes finish. Skin, no complaints of the skin.
Okay. Everything was smooth during when you were pregnant and when she was born?
Yeah, when I was pregnant and when she was born, everything was fine. But only one thing, she passed her poo late. She did not pass the poo the day she was born. She passed after 2 days. This was the only thing.
Then what they did?
Because of that, Yeah, because of that, the doctors did not discharge me. They kept till she passed the poo.
Okay, and did they mention you anything? Did they mention why this is happening or what they need to do further?
No, they did not mention me anything. They just told me that she needs a follow-up with the baby doctor. But I am busy in my family. I couldn't
Okay.
go. Then after maybe 2 days, she passed the poo, but still they did some jelly scan for her. And they said that the poo was not passed, but finally she passed. Then I was discharged, and they told me that this child needs follow up, but I did not follow with any of the doctors.
Okay. Did she got all the jabs?
Yes, till date, all the jabs were given.
Any extra jab?
No.
Okay. Apart from these problems, do she has any other medical problem or any time she has undergone any surgery?
No surgeries.
Okay. What about her diet? I mean, everything is fine. She's eating well.
Yeah, she is eating well, but her weight is going down despite of eating. As I told you, she passes
Yeah.
a very smelly diarrhea, which is difficult to flush. She is
Oh,
eating, but I feel there's some problem in her tummy.
yeah, we will figure that out. Do she has any allergies?
No allergies.
Okay. Any family problem of like similar problem in the family or I mean other
Yes,
siblings, they are doing
her
fine?
aunt. Yes, her aunt had this problem of coughing, and she died at a very early age.
Oh, I'm so sorry to hear that. Okay,
And
and
I don't know what's the cause of her death.
okay. So can you tell me how you're being coping up with this problem? And of course, she also has to struggle because she is having this problem for last 2 years, right? From birth, her second birthday, she's having this. So how you're coping with this problem?
Yeah, actually, the problem is of the follow-up. She had several admissions before. Maybe she already has 6 times infections of her chest, for which 2 admissions were in high dependency unit, and IV injections were given for her. So every time they asked me to follow up, this child needs follow up, but I did not. The reason is I am a single mother and I am earning and I have to take care of the family. So I don't have time to
How many siblings she has? Oh, sorry to interrupt. Yes.
two.
Okay.
siblings.
They are fine.
Yeah, they are fine.
Okay. And who is taking care of them when you're being in the hospital?
I leave them in the nursery,
Okay.
and when I come back, I will pick them up from the nursery.
Regarding, you told me that the admissions were done, right? At that time, did they run any test for her or did they mention what's wrong, why she's having any recurrent infections and anything like that?
Yeah, when she was admitted, she will be in a serious conditions. They say that the chest is infected, and they give antibiotics and they send lots of investigations. But they told me that we have to evaluate the reason for this, and you have to come to the clinic. But the thing is, once the child is fine, I will be busy. I have to go to the job to earn for the family because I have to take care of the children. I have no time to visit the OPD, so I did not come.
Okay. Are you receiving any allowances for her illness?
No,
Time
doctor.
over.
Okay.
Time over.
Okay. So can you present your case now?
Yeah. Can you give me just 30 seconds just to summarize? It's just to make sure I don't miss any finding. It's okay?
For me, okay, but I don't know in the exam they will give you
They will
30
not give. No, they will
minimum.
not. Okay. No.
Okay, just do it, no problem.
Okay, I'll just go with it. Okay.
Okay, go ahead.
Yes, Herring, 4-year-old with complaint of chronic recurrent chest infections, along with that recurrent diarrhea and abdominal distension, recurrent chest infections getting worse for past 3 months, and diarrheal episodes for last 2 years. With problems of she's not growing well and currently having exacerbation of her chest infection. Socially, she's not receiving any, mother is not receiving any allowances, single parent, having 2 siblings, and yes, family history in maternal aunt is positive for similar illness.
Okay. You missed something important in the presentation.
I think it's chronic cough and diarrheal illness and temperature. Yes.
Okay. Apart from that, something very important.
With recurrent admissions, you mean to say?
She did not pass the stool in the.
Yeah.
This is very important history, which you have to. You shouldn't miss. It will take you to your differential.
Yeah.
So she did not pass the poo in the initial 2 days. This was the concern. For that, she was asked for the follow-up, and because of her recurrent chest infections, she was asked, but due to social problems, the mother is not able to follow up.
Yeah.
This you missed.
Yeah. I should mention in summary. Yeah.
And you should also in the presentation, you should give the red flags. Like there was no blood or in the sputum or no blood in the.
I have to mention in summary also these things.
At
blood,
least
sputum,
the red flags which may give you the problems. At least these things. Okay.
Okay.
Okay, we will discuss later. So next, what is your differential diagnosis for this case?
My diagnosis, provisional diagnosis is cystic fibrosis, and the differential diagnosis could be immunodeficiency, or it could be tuberculosis, though I didn't ask for the family history. These 3 things.
Cystic fibrosis, immunodeficiency. Okay, anything else?
And tuberculosis.
You told tuberculosis. Okay, apart from that, any?
These 3
okay,
things.
no, we will discuss it later. So differential diagnosis finish. Now, how do you want to manage this case?
Okay, I'll for this patient as having recurrent chest infections, and currently also I'll after detailed history I will go for physical examination, and especially the respiratory system examination, vitals monitoring, and I'll admit this patient, and ABC is the first. If he needs oxygen, I'll put them on oxygen, and in IO charting, input and output, I will monitor. I'll monitor the saturation, and then I will go for a full blood count because it seems like an infection. So I'll check for, and child was pale as well. So I'll check for anemia, TLC count to rule out any infections, and I'll go for inflammatory markers, blood culture, and we will also send sputum culture. And we will also request for the previous sputum culture results if it has been done, as he has frequent hospital admission. Apart from that, I will go for lung function test, chest X-ray, and a peak expiratory flow. And I will go for a broad spectrum IV antibiotics, as in cystic fibrosis, the common bugs being staph and pseudomonas. So we will start with, if child can take oral, we will go for oral ciprofloxacin and tobramycin. First of all, sorry, before starting, it's a multidisciplinary team approach. We will involve pulmonologists, pediatric pulmonologists. We will involve gastroenterologist, dietitian, and social worker, definitely, physiotherapist, That's it. And we will start with broad spectrum antibiotics. If child can take orally, we will start with oral ciprofloxacin and nebulized tobramycin. Apart from that, physiotherapy. Sorry.
Ciprofloxacin they are giving for this age, 4 years.
No, under 8 years we are not giving. So we will give ceftazidime and tobramycin.
Okay.
Okay.
So,
and physiotherapy and mucolytics. Yeah.
So now, is this child diagnosed as cystic fibrosis? Is he by your history? Do you think that it is diagnosed or not yet diagnosed?
Still, it's not a diagnosed case because mother didn't.
What is the diagnostic test you want to do in this child?
In this child, we will go for sweat chloride testing. If it's being positive more than 60 MEq per liter, then it's diagnostic. And we will also, like, there are diagnostic criteria. If it's a positive, if typical symptoms in this child, and then along with that, if 2 sweat chloride are positive, this will be diagnosing the cystic fibrosis. Other testing is abnormal nasal potential difference and cystic fibrosis gene mutation. We will check for the genetic testing.
Okay. So you will go for sweat test and genetic testing.
Yes.
Because this child is still not yet diagnosed, you will first do your top of the differential is cystic fibrosis. But you will diagnose it with the sweat test, and even though the sweat test has the high chloride level, you had a history of the aunt being, but the mother said she don't know the diagnosis. So you have no confirmation that there is family history of cystic fibrosis, but there is suspicion. Okay. So after sweat test, you will go for genetic testing. How the genetic testing will benefit you?
No, I will not go. If, as in this child, there are typical features, I will go for sweat chloride testing. If 2 sweat chloride are positive, then I will not go for genetic testing. Yes, in genetic testing, if it's a particular mutation, delta F508, then there are some drugs which are immunomodulators, which are good for that particular mutation.
Yes, there is the good point about the genetic testing is sometimes it will help you in the management and the prognosis and the follow-up.
Yeah.
Okay.
So we will go for genetic testing, right? In all cases.
We will go through the NICE guidelines, but I think you will go for the genetic testing for the confirmation. Okay. For the confirmation, and also if there is no clear family history with the clear gene for you from the before, you will prefer genetic testing. The reason is, just 1 minute. See, the reason why we will go here for genetic testing is one thing, there is no confirmation in the family about the cystic fibrosis. Mother doesn't know about the aunt's condition. This is one thing. The second thing is there is no counseling for the family till now because they don't know that it is running in their family. One thing you missed in the history in such cases when you are suspecting cystic fibrosis, ask about the consanguinity of the marriage, which you did not ask. If you would have asked, I was prepared to tell you that my husband is relative and we are divorced, and so the aunt who was suffering was not from the maternal aunt, it was a paternal aunt. And she don't know. This was the story behind it, but you did not ask, so I did not tell. Okay. Maternal aunt, definitely mother would have known more details. It was a paternal aunt who had this problem, and they had a consanguineous marriage. So till now there is no counseling in the family. and they don't know what is the gene which is running in their family. If you see all these reasons along with the sweat test, you will go for the genetic testing, but still we can go through the NICE guidelines, what it says. Okay.
Okay.
So this is the things you missed. So as I know, when you told after the history, you will do the detailed physical examination, vital signs and detailed physical examination. You will check for the ABC of the patient, and this patient may need admission because this may be the acute chest infection. So you will go for CBC, CRP, blood culture, sputum culture, lung functions, chest X-ray, and you said peak expiratory. So everything was fine. Only missed by you was the because this case was not diagnosed. So you should tell the diagnostic investigation. Still, it is not. I did not tell you that she's known case of cystic fibrosis. Mother was asked to follow up many times and she did not follow up. The reason was the social. She's a single mother and she has to go for a job. She has no time to attend the OPD. Okay.
Yes.
So you missed was the diagnostic investigations, and in the multidisciplinary team, we will mainly say the CF specialist or the CF team.
Okay.
You will involve the CF team in which you will have the pediatrician specialized in cystic fibrosis.
Okay.
Okay. And you will have dietitian, that is good, and physiotherapist, a social worker, and as you said, even the pulmonologist and the gastroenterologist can be involved. I think that's it. Rest of the things was fine. Only we have to check for the culture and sensitivity to check for the antibiotics. But I don't think the ciprofloxacin will do in this child.
I think less than 2.
We can go through the recent things, no problem for the management.
Dr. Fatima,
Yeah.
I think flucloxacillin, more than 2 years, Cipro, like this. Is it?
Let us see the recent ones rather than wasting time. Maybe this, maybe that.
Yes.
Dr. Fatima, I have gone through NICE guidelines. I have gone through NICE guidelines. Yeah.
Okay, wait. We go through the management. Before that, I will just give you the feedback what you missed in the history, okay? And then we will go for the management.
Okay.
Yeah, just one comment is about the sputum color. Usually it's white. This color, it doesn't reflecting the patient has pseudomonas. Pseudomonas is greenish color, and then dusty color is the aspergillus.
No, it's Burkholderia or aspergillus for dusty.
Pardon? Dusty color of the sputum is aspergillus, and then greenish color is the pseudomonas. It's white color usually. Usually, as just now one of the doctors says, actually first line antibiotic for more than 2 years is a flucloxacillin because the common bug for that age is Staphylococcus aureus. So anyway, we still our antibiotic choice is still based on the sputum culture result as well.
Yes, sputum culture is the ultimate thing for you.
Yeah.
Burkholderia cepacia, bright red. Am I right?
Pardon?
Burkholderia cepacia.
Burkholderia cepacia. Wait, I let me check. I double check the colors. Then I will post in the group for you all.
Okay,
different colors. I wrote in my books, but I need to double check so that I don't want to give wrong information to you all. Later I will share in the group. Yeah.
Thank you, doctor.
Just 1 minute, I will mute all. I will just tell what Dr. Vindhya missed in her in her history. Did you ask about GP, what he did? Did you ask her? I think you did not ask, right? What the GP did for you?
I missed what has been done so far regarding
what
his,
has been done so
that's
far was missed for
that-
you. If you would have asked me, I would have told you that the GP told that this may be the chest infection and he started on co-amoxiclav, and the patient is on co-amoxiclav from 3 days with no response. Mother sees no response, and also the ventrally nebulization. You asked for the cough, that's why I told you. But if you would have asked what done so far, did GP do, you should ask, here there is no follow-up. But you will ask about, did GP do anything for you, like the tests or any medications? The GP started her on these antibiotics and asked her to go to to you. He referred to you for the further management. Okay. So this history you missed. Then for always, as there is an association of as there is chronic diarrhea as well, take more history, but you covered, I feel. You asked about any blood in the stool. Okay. Apart from that, you should have asked about the pain, and I also told about the tummy distension. Little more you would have asked any admissions for this, for the purpose of this. Regarding the admissions, you did not ask by yourself. I just told it off to give you a clue. Okay. You asked about surgeries, but you did not ask about admissions. When you asked about surgeries, I told no surgeries. So be clear when you ask the past medical history. When you ask the past medical history, ask for admissions, because this is chest infection, right? By the history, you're thinking this chest infection. Asked any admissions for similar condition or similar reason. You asked for surgeries, I said no surgeries. But if you would have asked for admissions, I would have told that she has 2 admissions.
And the result of the previous sputum, if she knows.
Yeah. Definitely mother would have told you no, because she's not following up with the things properly. And she don't want to give you the clue also of what is happening with the child. That's why here everything they will tell that mother don't know. That's how the role player will tell. There is some problem in the family, but we don't know what it is, because you are the one who will give them the diagnosis. Okay. So what done so far was missed, and you asked about the aggravating and relieving factors, and allergies was asked. Nutrition, height, weight, nutrition also was asked, and I told that eating well but losing the weight due to the diarrhea, and there is difficult to flush. This is very important. In the systemic review, what you missed was the ear infections. You asked about hearing, but you should also ask about ear infections. Why?
Because of primary ciliary dyskinesia, but I asked, do he's having more ear block and nose blocks and ear infection? Did it? I think I have asked. Maybe I forgot. I don't.
No, nasal block I wrote, but ear infections I did
maybe
not.
I missed. No problem.
Yeah, you asked the nasal block, but ear infections. But the good thing is you asked about skin infections. So ear infections, skin infections. You should also ask about any ulcers in the mouth. Okay. Why all? What these 3 things are for? What? Ear infections, skin infections, mouth ulcers, and chest infection and diarrhea. All these combinations.
Immunodeficiency.
These all other things except this mouth ulcer goes with immunodeficiency. Mouth ulcers mainly for Crohn's.
Sometimes even in the immunodeficiency, you can have this fungal infections, candidal infections.
Okay. So I was thinking to keep this also, Crohn's also in the DD.
But the child is still 4 years.
Yes.
Less likely. So
yes.
here,
age is celiac we can keep.
Head to toe, you will ask about. Yeah, repeated ear
celiac we can keep.
Yeah, skin infections and any ulcers or any lesions in the mouth. You can check for the fungal infections or repeated viral infections and diarrhea, chest infections, all these things for the immunodeficiency. Then you ask for the pee and the poo, which is good. The thing, one more which you missed importantly was the skin rash. The skin rash is for what?
Eczema, any allergies? Because recurrent chest infection or skin infections?
Yeah, rash is for also for this celiac disease. You get something near the knees and near the hands, right? There is a chronic diarrhea with difficult to flush. And also for the asthma, you can put asthma also as the down in your differentials.
Actually, then we cannot fit the diarrheal illness in that, isn't it?
Yeah,
That's
yeah.
why
As I told you, that the top two will be your most likely diagnosis. Down, you can say that this is this, but less likely because of this reason.
okay.
Okay, like that.
If you have to add the asthma along with the diarrhea, even though your history elaborates more of a cystic fibrosis or an immunodeficiency, cow's milk protein intolerance was also something that I had written.
Yeah. Cow's milk protein intolerance also can be, but the thing is here, her problems started after the second birthday.
Sorry. So cow's milk protein intolerance, you can have diarrhea, you can have dry skin, you can have recurrent coughs. So, yeah.
Yeah, but it started after 2 years.
Still
You,
it should, okay, yeah. So it doesn't fit.
But still you have to ask some questions about the weaning and all those things because of the celiac disease. Like after you started weaning, did you face any problems? But the mother here is giving you mostly after 2 years the problems started. So less likely, but still you have to put in your differentials. The differentials which you missed was the celiac disease and asthma, which you will be putting as lower down. Your top will be cystic fibrosis, because this is the condition where you will have chest infection and diarrhea both, and also immunodeficiency. Okay, here you can get multiple varieties of infections. The down you will put celiac disease, where you are supporting only for the diarrhea, but your support for the chest is not there, but still you will put it as the lower down. And then asthma as last, but you can tell these two are less likely.
Dr. Noor, somebody is just
Yeah.
Yes. Chest infections can be there in malnutrition. So rather to go for celiac disease, malnutrition we can go for. It will cover celiac disease and other things, because in the malnutrition there can be recurrent chest infections also.
Yeah. Now these two, the difficult to flush stools, will give you the idea of cystic fibrosis and celiac disease.
Yeah, celiac, malnutrition. Also malnutrition is also, this is the part.
Yes.
Dr. Noor, just somebody is writing in chat that can we put COVID in this? I think they're asking for differentials.
I don't know, because with the family history and with the long-term history.
This one of COVID, the MIS, but I think this is a chronic condition. For the MIS, if there is yes, GI manifestation, it will be just acute. This is my opinion.
Yes, it's since birth problem has been started, and then it was an ongoing problem. So chronic, I mean, COVID, me, I think as for me, it doesn't fit in this scenario.
According to our examiner in Malaysia, they say they won't ask any questions about COVID.
Okay. So anyone, these are the things she missed. She missed for the consanguineous marriage. She did not ask. When you are suspecting any family, the diseases running in the family, please ask for the consanguinity in the marriage. And this she did not ask. About the past medical history, you should be very clear about the previous admissions. Development, you did not touch at all. At least you would have asked one, is her development same like the peers? Okay. You did not ask about the development. This only significant history here in the birth history was delayed passage of the meconium. This was the only history which you elicited. Otherwise, I think the rest of the things were fine. Only some things which you missed are very important. Whenever there is a case going with cystic fibrosis, celiac disease, malnutrition, also keep immunodeficiency in your mind and ask for these things when you are doing the systemic review. Ear infections, any ulcers in the mouth, or any infections you see, and repeated skin infections, or repeated chest infections, diarrhea, bloody sputum, blood in the stool, high grade fever, all these things becomes important, and admissions before becomes important. Okay, so in my case which I presented, the top differential is the cystic fibrosis, then immunodeficiency, then celiac disease, then last will be the asthma. Okay, as you can tell, less likely, so you will put it as the last. Okay, tuberculosis I will not go here because I don't think by the names I gave they are coming from the endemic areas. This is one thing, and no other features also in the history. So I think don't say tuberculosis. Anyone wants to add here anything? So anything we missed? Anyone who attended the whole history can add.
Follow up, like how will you take the follow up the CF child?
Yes, as we said, multidisciplinary team involvement. There will be a CF team which will consist of a pediatrician specialized for this condition. Okay, and dietitian, physiotherapist, especially for the chest physiotherapy, social worker, education is very important, genetic counseling, geneticist is very important. Here you have to do the genetic testing, and if it comes out to be positive, genetic counseling is more important.
Yes.
Okay.
Gastroenterologist.
But still we have to go through the things.
Yes, yes. There is a specific, like annually, they repeat the X-ray like this. In the guidelines, they have written like annually we have to repeat the X-ray, weekly pulmonary function test, criteria for admissions, all those things we have to see. Okay.
I would like to add one thing. Dr. Bindi asked in the question about the antenatal history, and she asked whether the pregnancy period was smooth and there was no event. In the exam, the role player will not give the answer if he did not ask the specific question. If you want to know a question regarding delayed meconium, we need to ask the specific question. Dr. Noor has nicely given all the information, but it's not possible in the exam that just by asking a simple question, they'll give you all the positive and significant history.
I agree. Yeah.
It should be a specific question, otherwise they will not give answer because they don't know what is the importance of delayed passage of meconium. They don't know whether the baby has passed motion on second day, so that was something abnormal. They might think it is a normal. So that I mean, this is just one point I want to add.
Yes, yes, I agree.
So we will just, this is from the NICE guidelines. We will just read for the diagnosis of the cystic fibrosis. Be aware that cystic fibrosis can be diagnosed based on, based on positive test results in people with no symptoms. For example, infant screening, blood spot immunoreactive trypsin test followed by sweat and gene test for confirmation. Okay, so no symptoms, you did the blood spot screening for the neonate and there was positive, you will go for sweat test and gene test for confirmation. Suppose now, like our child, clinical manifestations, you have to be supported by sweat or gene results for confirmation. Clinical manifestations alone in rare case of people with symptoms who have normal sweat or gene test results. Despite the normal, he's telling, despite the normal sweat and gene test results, if the clinical manifestations alone are strongly suggestive for you, this will be in rare cases, very rare cases, you can diagnose, but I'm not sure how far they are doing this. Assess for cystic fibrosis and when clinically appropriate, perform a sweat test for children and young people or a cystic fibrosis gene test for adults in people with any of the following. So family history, congenital intestinal atresia, meconium ileus, like symptoms and signs that suggest distal intestinal obstruction syndrome, faltering growth, undernutrition, recurrent and chronic pulmonary disease such as recurrent lower see in our child there was delayed passage of meconium and there were recurrent lower respiratory tract infections. Okay, persistent chest x-ray changes, chronic wet or productive cough is also an indication to go for the testing of the cystic fibrosis, chronic sinus disease, obstructive azoospermia in young people and adults, acute and chronic pancreatitis, malabsorption, rectal prolapse, and pseudo-Bartter syndrome. Refer people with suspected cystic fibrosis to specialist cystic fibrosis center. If they have positive or equivocal sweat test result, their assessment suggests that they have cystic fibrosis, but their test results are normal. Genetic testing reveals one or more cystic fibrosis mutations. So all these people whom you suspect they have cystic fibrosis, you will refer to cystic specialist cystic fibrosis center. Okay, either you should have positive or equivocal sweat test and also symptoms suggestive of cystic fibrosis, but still their test results are normal, which are the rare cases which we studied, and genetic testing. Now my question is, does all the patients need genetic testing even if the sweat test is positive? So anyone has this information from any pages of NHS or the NICE guidelines?
This sweat test is not confirmatory, Dr.
Yeah,
Fatima.
this is what I remember. But here he's telling or, in some cases he's telling sweat test or genetic test. Why he's telling like that, I don't know.
But
sweat test is gold standard, Dr. Noor. Sweat test is gold standard. Sweat test is gold standard. Okay, after newborn screening, sweat test. We usually do two sweat tests. Okay, then it is gold standard actually. Because
for confirmation you can do twice, as Tamanna is saying, and it's a gold standard. If you have all clinical symptoms, manifestations, and you have positive tests, we don't do in our hospital also for the genetic test, but only for in some doubt you will do the gene test. If you have confirmation, if you have family history, if you have a sweat test positive, khalas, that's enough.
Yeah, another is delta 508, that gene. That gene is only 75% positive. So 25% cases you will not find delta 508. And other genetic study is not available. So only delta 508 gene is we can testify.
70 to 80% now. Now currently 80%.
Yeah, so we cannot say that gene study is confirmatory.
But this is the only test we left with, like sweat test?
Yeah, Tamanna, wait 1 minute. What I understand is you will do the sweat test. Once it is positive, you will repeat it again 2 times, right?
Yeah.
If it is positive, it's confirmed, you mean?
Yes, confirmed.
Yes.
Second time you are doing, second time why you are doing? Just to exclude any false things and to confirm.
To make the board test.
Then when they will opt for genetic testing?
If you have any doubt.
Yeah.
Like in my patient, there was some family history, but it was not diagnosed with cystic fibrosis. So they are not sure about the cystic fibrosis in the family. They are just suspecting. In
those
this
cases,
case,
you will do.
even though the 2 sweat tests are positive, you will go for gene test or no?
No.
No.
2 sweat
You need to
Doctor,
have some test.
What about
Dr.
for the
Fatima?
genetic counseling and to see for the
Yes.
prognosis?
Sibling also have to be like, you have to see the risk. Like other family members are getting involved or not. You have to study the genetic testing. Once you are confirming, I think it's important because in this also we do. Celiac also we do to screen the other siblings. So I think this genetic testing is important, I think.
You have this
I
screenshot
don't.
anything, Tamanna, for this? You have?
No, it's not in guideline. It is not in red book. Okay, it is from
It is
the
not written in the red book actually.
book, yeah.
Genetic testing they are not doing because this is only 80% delta 508 is you can find out. The others there are mutation. I think 502 or something 500
508.
mutations are there. No,
Yeah.
this is 508 number.
508 is the
More-
common one, which is 80%.
This is the common one. There are more than 500 mutations, so you cannot find out each and,
it's not
everyone.
Yeah,
So
it's
that's
not
why
present
two,
in guideline.
yeah, two
red
is
book.
the gold standard, and you after that you can confirm.
Yeah, and sometimes Carter-Jenner syndrome, other diseases that can mimic like cystic fibrosis. In those cases, for differentially, we exclude by the genetic study sometimes, because in those cases, sweat chloride may not become positive. Okay, but I will post the guideline, the recent one. I'll post. Okay.
Which guideline you're telling? NICE or what?
Yeah, NHS. Yeah, it's not in red book. Red book only admission, then microbiology, then intestinal obstruction.
I did not get even in the.
No.
I didn't get even the even in NICE guidelines. I did not get the correct answer for this for the diagnosis. So if we admit our patient because there is recurrent in this case, definitely it's good to admit this patient because there is history of recurrent infections and mother was asked to follow up many times and she did not follow up. Needs to evaluate this child to give the best treatment. So what do you do with CF team and what sister? There will be a CF team who will be managing these patients. Okay. Refer to admission plan in notes and clinic letter. Always admit to a cubicle, means there will be isolation for them. You will admit them in a cubicle. Plot the baseline weight and height. Perform volume loop spirometry on the admission day. So what we said, lung function tests is very important in these patients. And review drug history, but here it's written more than 6 years. Our child is 4 years old. So review drug history with patient, parent, carer. So past history of the drugs, medications has to be taken. Prescribe all medications. Check whether annual bloods could conveniently be taken now. Ask nursing staff to inform physiotherapist and dietitian on the day of admission. Check specific aspects of management and investigations as described by CF team. So investigations, what do you do? FBC, full blood count, urea and electrolytes, CRP, blood cultures. This is LFT, right? Or the lung function tests. LFT. Okay, so if allergic to bronchopulmonary
is liver function tests in that context.
Yeah, liver function test. Yeah. If allergic to bronchopulmonary aspergillosis suspected, request. So if you think that there is allergic bronchopulmonary aspergillosis, you will go for IgE also. Only in cases of suspicion. I think, how do you suspect? By sputum color, right?
Yes, sputum color, and if you have given antibiotics, still there are worsening. I mean, each child is not improving in such situation.
Okay, what will be the color of sputum in this allergic bronchopulmonary?
I have written in written in chat. Actually, the color, if the color is green, then it is Pseudomonas. If the color is dusky, then this is Burkholderia. And if it is the color is dark brown, then Aspergillosis.
Okay. So important things, all these things were told by our candidate. She told FBC, CRP, blood culture. She did not tell for the liver function test, as I remember. Sputum and sputum swab for culture and sensitivity. This was told, and if clinically indicated, consider sending nose and throat viral swabs as well. If non-tuberculous mycobacteria infection suspected, some send sputum for NTM culture. Repeat sputum and cough swabs per week. Okay, if new pathogen found, see cystic fibrosis microbiology guideline. So chest X-ray, if new clinical signs are present when examining chest, order chest X-ray. Mostly child have chest X-ray every 12 months. Check when last one was performed. If in doubt, discuss with the CF consultant. If new chest X-ray performed, always compare with the previous. If recent CT performed, review findings and discuss with the CF consultant and radiologist. So lung functions, when do you do? Perform spirometry on admission, then weekly on all children who blow reliably. This is for the more than 6 years. So always when we are presenting the case and we will present, we have to see the age of the child also. Who will do these lung functions? Undertaken by physiotherapist or trained nurse. If evidence of airway obstruction, repeat spirometry 15 minutes after inhalation of salbutamol 4 puffs via spacer. So you will basically do the lung functions for more than 6 years old child. If you, by the lung function, if you got to know that there is obstruction, you will give the salbutamol 4 puffs and you will repeat it after 15 minutes. Monitor oxygen saturation overnight for the first 2 nights after admission. If saturation less than 91%, prescribe oxygen via nasal cannula or face mask. So you will be continuously monitoring the oxygen saturation. Approximately 8% of children with CF develop diabetes after 10 years, usually manifests by weight loss, and ketoacidosis is rare. So more than 10 years, they have a risk for diabetes, but without ketoacidosis. If taking regular oral corticosteroids, screen for glucose intolerance at admission. During the first 24 hours after admission, request finger prick blood glucose before breakfast. I think, but this is only for children above 10 years, right?
Yes, doctor.
No, actually this one is if he's taking regular corticosteroids. This one is for the corticosteroids.
If prednisolone started or dosage increased during admission, repeat finger prick blood glucose. If blood glucose elevated, discuss with CF team. The reason to take corticosteroids in this patient is this bronchopulmonary aspergillosis or what?
What the question?
Why they take corticosteroids for this allergy?
Yeah, they are giving in the aspergillosis. Yes.
Or aspergillosis. Okay.
But doctor, it's OGTT is recommended after 10 years, isn't it?
Yeah, for CF related diabetes mellitus, that is 10 years or more than 10 years. But here it is if the case was aspergillosis and he was on corticosteroids, then you will have to do glucose tolerance test at the admission. Then during first 24 hours after the admission, you will do the breakfast, before breakfast, 1 prick, and after every meal. Okay, and in the overnight at 2 a.m. also.
Okay.
This is for the corticosteroid. That is annual assessment. If they have written, I think in the next page, there is annual screening, there is annual assessment.
Yeah, there is here. I will go now.
Yeah. Annual screening, different annual assessment. Yeah.
Annual bloods. All children attending CF clinics should have annual blood screening. Perform annual blood screening if admission within a month of annual screening. Okay. Insertion of long line or a portacath needle, or when checking tobromycin level. So annual screening you will do, and also if the child is in a need of portacath or long line, whenever you put the line at that time also, if you can extract for annual blood, it will be extracted. And also when you check that if the child is on thromboamycin, to check the thromboamycin level. So all ages, what do you do every yearly once? FBC and blood film, vitamin A, D, E, because we know that there will be loss of fat soluble vitamins. So A, D, E, and also K. Why they did not mention K here? I don't know.
Oh, that we will monitor PT. We don't check the level of vitamin K.
Okay, for checking. Okay, so vitamin A, D, E, parathyroid hormone, and urea electrolyte, CRP, LFTs, chloride, bone profile, magnesium, Pseudomonas aeruginosa antibodies, glucose, and total IgE and specific IgE to Aspergillus and Aspergillus precipitans. So we should remember these. What are the annual blood tests we do in cases of cystic fibrosis? One is the full blood count and the film, fat soluble vitamins, that is A, D, E, parathyroid hormones, urea electrolyte, CRP, LFTs, chloride, bone profile, magnesium, and antibodies for Pseudomonas aeruginosa, then glucose, then IgE total and specific for Aspergillus and Aspergillus precipitans. This we have to make list by ourselves and remember all these things. If more than 10 years, then add glucose tolerance test. Okay. But here we were discussing here, what we were discussing is if the child is on oral corticosteroids, even if he is less than 10 years, we will screen for the glucose tolerance at admission. This is what is given here. Okay. So nutrition, always involve dietitians, weigh twice weekly in night wear and before breakfast, weigh babies naked if possible. So to reduce the cloths, weight of the cloths. So twice weekly, especially in the night wears. Continue normal supplements. Pancreatic enzyme supplements, continue same type and dose of as already prescribed. If the child is on, if he is new case like ours and if he gets diagnosed, you should start all these things, pancreatic enzyme supplements. So starting dose for newly diagnosed, all these, I think no need to remember the doses, just we should know that we should start the pancreatic supplements, which is by the name Creon. For the dose, no, I don't think they will ask. So children starting dose, they have given here, you can go through. So signs of malabsorption, fatty pale stools, frequent smelly orange oil, excess flatulence, abdominal pains. So what I told you, in our patient, we had all these things, smelly, difficult to flush stools, okay, and abdominal pains and sometimes abdominal distension. So the treatment for this is you will start with the pancreatic enzyme supplements and also the fat soluble vitamins. Next, signs of malabsorption, finished. So H2 receptor antagonist, if you are taking large doses of pancreatic enzymes, discuss with CF team to need for ranitidine to reduce deactivation of pancreatin. So we will add H2 receptor antagonists like ranitidine, so that the pancreatin which you are taking by mouth should not be deactivated. Okay. So, but all these things you will discuss with the CF team. So, vitamin A, D, E, starting dose, and oral sodium chloride. Doses and all we will see by ourselves. So, anyone wants to give any comments before we end?
No, it's fine. Thank you, doctor.
Is Creon prescribed for everyone as a standard across board, or do we have indications for prescription of Creon in cystic fibrosis?
No,
It's
Creon
not
is from
prescribed for all, you mean?
all, yeah.
It's prescribed for all.
Okay.
Because from the beginning, they have problem in the pancreatic.
All right.
Exocrine, yeah.
Yeah, here it's written, you see, infants you will give to the children, okay? So even from the as soon as the child is diagnosed with cystic fibrosis, you will start with all these things, pancreatic enzyme supplements. And if you are giving the large doses, you will consider H2 receptor antagonists. Okay. And also you will supplement with vitamin A, D, and E.
Yeah, this is ADEK is almost every annual screening they are checking for that.
I asked why K is not there. So what someone answered?
Yeah. K is given at the birth, and then I think
you will just
for the
PTPTT.
PTAPTT will monitor, and there is one for the newborn. We see PIVKA, protein induced vitamin K something. PIVKA is the short form. That we cannot measure this vitamin K. And there is a easy mnemonic which I remember for this, for the biliary atresia patient. Usually we give vitamin A, D, E, K. So the doses, how I remembered was 5. Like if you go 5, starting with K, A, D, E, K. So 5, then E 50, then D around 500, and this will come around 5,000 to 10,000 like this. So 550, 500, 5,000 to 10,000, something like this. I remember. I will post. There is an easy mnemonic like this. Because this can come in biliary atresia also. But I think they won't ask us dose.
Yeah, they will
No,
not
no
ask.
one
Just
asks
should
doses
know
at
that
all.
Not needed. Those they don't ask those. Those
They
not
don't.
needed.
Okay, fine.
so. This is written in here. How will you review the patient like newborn baby, and his IRT is positive, and he's now diagnosed with cystic fibrosis? How will you review? How will you follow up?
We will do the sweat test, right?
No,
In
you have
unit
diagnosed.
test you can't do. Sorry.
You have diagnosed case. This is from the neonatal period. IRT was positive. Then you have done the sweat test. I think that is done after 3 months of age. So
that is not done in neonatal period.
Yeah. There is a routine review is weekly for the first month, then 4 weekly, 1 to 12 months. Okay, then every 6 to 8 week, 1 to 5 year of age. Okay, this like this.
Now, what do you do in this review now during the neonatal period?
Yeah, they are reviewing any new symptoms. They are reviewing for the growth and development for this.
Any symptoms and any vomiting?
Yeah, because Dr.
Symptoms,
Fatima.
growth and development.
Yeah.
Follow
Dr.
up, they
Fatima,
can ask
same
you.
as any like we see in congenital hypothyroidism also. If you see, like initially they do screen frequently, and later as a child grow, they go with the annual screening, right? Similar as congenital hypothyroidism. Somehow the period
First
is
month, every week they will call. They can call you every week. Then 1 to 12 months. And if I mean to say first 1 year, they will call you every 4 weekly, every month. Then 6 to 8 weekly, 1 to 5 years of age.
Okay, regarding the antibiotics, Dr. Bindya was telling, see here, means he has written for the Pseudomonas here. If symptomatic, if asymptomatic with first isolation, you will give ciprofloxacin even from the age of, but if asymptomatic. But in our case, who is symptomatic and if diagnosed with Pseudomonas, then you will go for this tobramycin and ceftazidime. Okay.
Yes, this is ceftazidime and tobramycin. And nebulization is called cholistemeth.
Yeah. Cholistomethimate sodium. This is the nebulization. In symptomatic cases, you will go for this. In asymptomatic cases, but just you isolated from the sputum, you will go for ciprofloxacin in these patients.
Yes,
okay?
only
Even
in
he has written from 1 month to 18 years. No problem.
Yeah. And if it is chronic infection, Pseudomonas, this is not first isolation. If it is chronic, Then tobramycin, aztreonam, and this nebulization with the coli.
But if we apply for our patient will be patient newly diagnosed with CF. If our patient gets diagnosed with CF, then prophylaxis with flucloxacillin. If newly diagnosed patient has chest infection requiring antibiotics, commence cefuroxime. He's telling till you get the sputum culture and sensitivity, you will begin with the cefuroxime in our patient, which we are still suspecting and still needs to diagnose. But meanwhile, don't go for all these antibiotics. You can say that IV antibiotics, and I will discuss with my consultant. This will be the best answer, I feel, in this case, before the cultures are out and before your confirmation of diagnosis. But still, if you want to give any answer, you can give this. This is better, because even the sputum I said was whitish, not greenish for you, which is not going with Pseudomonas. So you can just say you can commence with IV antibiotics. If they ask particular, you can say this cefuroxime for cefuroxime IV. Okay, but I don't think they will. Do they ask for particular, or if we say that we will discuss with the consultant, it's more than enough?
In our exam, they don't want us to know the name which you want to start the septic edema tobra. This is actually the role of the CF team. So you should be on safe side. You will tell about the which doctors you would like to involve and what the things you further you are thinking in your mind to start. Like some antibiotics will be started, broad spectrum antibiotic will be started, and physiotherapist and other things, dietitian, nutritionist, I mean, and this pulmonologist, CF team, you will refer to that, and you will educate the parents and educate the patient and parent about how to do the physiotherapy frequently at home, and how to keep the follow-up with the GP doctor or CF team. These things you should know. They will not ask you which treatment you are going to start. If the asymptomatic and you are going to start ciprofloxacin or symptomatic, they will not ask you. This is not our level. This is the level of CFT.
And also this lung functions is done only for more than 6 years, right?
Yes, this is
so
just
better for the child is 4 years. No need to mention this here, both peak flow and lung function, both.
Yes.
To be unsafe.
Yeah, because child
we tell this.
Yeah, because child need to be cooperative to do that.
Yeah, so other monitoring like the saturation and see his condition like this. For the lung functions, better to. So Bindya, remember to see the age of the child before mentioning the lung functions in the exam. Okay. Okay, so if any comments, you can message in the group. I will end the meeting now. Okay.
Yes, thank you very much.
Okay, thank you very much.